Long-term treatment is very much a very generic description of treatment which is meant to be for more than fixed 6 or 8 or 9 cycles, which we have had in the past fairly regularly, and in some study designs still part of the treatment plan. That wouldn't be considered long-term treatment. Long-term treatment or extended treatment would be considered when we either have treatment until progression. That's definitely extended treatment. That's rarely used in newly diagnosed patients who achieve so frequently such a good and deep responses that even extended treatment may be fixed. For example, in our KRD trial, the extended treatment was for 24 cycles for 24 months, which is very long, but it's and extended, but it's not indefinite. To be able to treat for a long time is actually very important, which is important addition to our understanding how to treat myeloma in recent years. There are maybe two aspects or two data sets which can support my very general statement. Number one, for patients who achieve response but not necessarily complete response, the first study, the study conducted in France in which patients were treated with lenalidomide and dexamethasone for 18 months versus until progression, showed that those who were treated until progression had longer progression-free survival, which it may be interpreted that was reflecting that the patients in good control of the disease had an extended control of the disease if treatment drugs were still used for extended period. The second important observation supporting extended treatment is related to best responses. We have learned, which is another very important observation, that achieving complete response, and now we say MRD negative complete response, MRD stands for minimal residual disease or absence of any detectable disease, that those responses are achieved sometimes very early, but for the most part, then analyses have been done in multiple studies. We've learned that achievement or time to achievement of this deepest response associated with longer remission is on average somewhere in between 12 and 14 and 16 months even for most active regimens. Again, this was observed in multiple studies now in the Kaplan-Meier curves, which are evaluating time to certain level of response, in this case, complete response. We have found that extended treatment is critical. To just give specific rough estimates, we would have treated with KRD patients for 8 cycles only. At the end of 8 cycles, there is some variability between studies, but probably somewhere between 30 and 40% of patients will achieve complete response. Extended this treatment beyond 8 cycles increases the rate of complete responses to over 50 to over even 60%. That is an important observation, which in a different way supports my initial statement that treating longer rather than shorter is important. Now, I would add to that an important comment. We know from the first study that indeed longer treatment was important for prolonging remission. Whether achieving complete response and MRD negative disease is always as important for every patient, that's not necessarily established. But for statistical assessments, a patient who achieved that level of response will have to be predicted to have longer remissions. So achieving that level of response will statistically predict longer remissions. So in both scenarios, longer treatment is important. I think that we may have to potentially start scaling back extended treatment if, for example, certain levels of response are achieved. But that's the work which is ahead of us, and we don't have this information.